Sir, your Aster, or they have formally withdrawn from this meeting, because they don't seem to be coming.
They have not formally withdrawn, but they're not participating anymore now. So you think about it, whether we should call it Sagar Aster or leave it like that, or revert to the Sagar group. Let's see. Yeah. Good evening, everybody. Welcome to this journal club on what I thought was an interesting paper. Sorry about this background noise, but we have to, I guess, live with it. The paper deals with the value of preoperative ultrasound examination of the neck in thyroid malignancy. This has always been one of our difficult areas. This paper throws some light on it. I'm a little skeptical because the fact remains that ultrasound is observer dependent, and one has to be aware of the local expertise in as far as the ultrasound reports are concerned before you can take a firm decision as to how you plan your clinical approach, how you plan your operative approach, based just on the ultrasound findings. But anyway, let us look at this, address the issue of ultrasound that has been quite nicely addressed. There are some limitations in the paper, and I'm sure Indraja will highlight those. Over to you, Indraja.
Yes, sir. Good evening, sir. Sir, is my screen visible, sir?
Yes.
Hello.
Sir.
It is visible and you're audible. Please go on.
Okay, sir. Good evening to everyone. I'm Dr. Indraja, second year surgery resident in Saga Hospital. Today, the topic for General Club is preoperative nodal ultrasound features for predicting the recurrence in N1B papillary thyroid carcinoma. It is a retrospective study conducted by Na Le Yun et al., published on 30/12/2021 in Cancer's Journal, and it has an impact factor of 6.63. We all know that papillary thyroid carcinoma, it is the most common malignancy encountered in the head and neck region, and it accounts for around 90% of the thyroid malignancies. As lymph node metastasis is most commonly seen in the papillary thyroid carcinoma in the central and lateral neck, it has a prevalence of around 20 to 90%. And the presence of lymph node metastasis in the lateral neck, and which is staged as N1B, associated with high rate of post-treatment recurrence. Because of its high recurrence potential and high morbidity rate, so risk stratification of PTC N1B is important in order to determine the surgical extent and post-treatment surveillance. And thyroid ultrasound, it is a non-invasive diagnostic modality, evaluates the thyroid glands and lymph nodes, and it is routinely used in the staging for thyroid cancer in preoperative settings. On ultrasound, the lymph node metastasis is associated with following features, which includes the shape, round or irregular, and presence or loss of hilum, and hyperechogenicity, cystic changes, and calcifications. The aim of this study to investigate whether ultrasonographic features of the metastatic lymph nodes are associated with recurrence in patients with N1B papillary thyroid carcinoma. It is a retrospective study accepted by Institutional Review Board. It includes a total of 837 patients who were staged with N1B on preoperative ultrasonographic findings and who underwent total thyroidectomy and lateral compartment lymph node dissection between January 2009 to December 2015. And they excluded the patients based on the following criteria. They excluded, which includes patients with thyroid cancer other than papillary thyroid carcinoma and who had distant metastasis at the time of the diagnosis. And they also excluded the patients with other malignancy at the time of the diagnosis and patients who had proven negative lymph node and pathological examination. And they also excluded the patients who had follow-up period for less than 12 months. So finally, they included around 692 patients who were staged with N1B and underwent total thyroidectomy and lateral compartment lymph node dissection and who were followed for at least 12 months of the period. Out of these 692 patients, females were 464 and males were 228, with a median age of 41 to 43 years. Ultrasound examinations were performed with 5 to 12, 4 to 15, and 6 to 18 megahertz linear array transducer, and it is performed by one of the 6 radiologists who had experience of 5 to 18 years in the thyroid imaging. And ultrasound images of the index cancer and metastatic lymph nodes in the lateral neck were retrospectively reviewed by 2 radiologists, and the tumor size was determined by maximum diameter of the index cancer.
Yeah, just one sec.
Yes, sir.
Indraja.
Yes, sir.
Just go back one slide. Yeah. Pavan, are you there?
So Pavan is in emergency, sir. One
He's in an
emergency laboratory.
emergency.
Yes, sir.
All right. Okay, maybe I could ask Hari himself. These megahertz values that are given, why is it important to know this?
Sir, to know the depth or what mode of ultrasound should be used.
Why is that important? Yeah, it tells you the frequency of these
Yes, sir.
waves that the probe uses, but why is that important?
So because in this study, we are studying about the ultrasound imaging factor that determines the recurrence. We are studying that. So for example, the mode of ultrasound differs with each, like A mode, B mode. So for thyroid superficial structure, and it differs from abdominal organs examination. So it is important to know it is same for all the.
That is the important point. You sort of could have said it very quickly and easily.
Yes.
It has to do with the depth of examination.
Yes.
Okay, if it is more superficial, the structure, higher is the frequency of the probe.
Yes.
All right. So this is a superficial structure, and so you're using this. All right,
Yes.
Indraja, you talked about the institutional review board.
Yes, sir.
We don't have it. Where do we get our permission from?
From ethical committee.
So how are the two different? They're not different.
Okay.
All right. The same process, the same committee.
Okay.
In certain countries is called the institutional review board.
Okay, sir.
All right. Okay.
Yes, sir.
Continue.
Okay. And index cancer was assessed according to the following characteristics, which includes shape, which is
You have done this. Go to the next slide,
Yes.
please.
In Indraja,
Yes, sir.
sorry, sir, one question.
Please.
There is a statement saying that these the ultrasound features of the lymph nodes were reviewed by 3 radiologists, and then the consensus was agreed. See, how did they do that retrospectively? Have they explained it? For example, how
They
can
have
you do?
studied the images, sir, ultrasound images retrospectively.
So would they store the images and then go through it, or is it just the printout that they give, usually what they give here?
They have said that, sir, they have studied those images retrospectively. In this paper, they have mentioned that one.
Yeah, the
Yes,
details are not given, but
Details are not
given, but one presumes that these 2 radiologists who are experienced reviewed all the images who were selected for the study.
So they would have probably got it on a capsule. This one, I think.
They would have it on disk.
Store on disk or something.
It'll be on the hard disk. They'll have seen the whole examination. Yeah.
Okay.
Let's continue, sir.
Yeah, please.
And for the lateral lymph nodes, index lateral lymph node was determined to be the lymph node with suspicious features and larger size. The features of index lymph node as assessed follows, with longitudinal diameter and presence of cystic or solid components and calcifications, hyperechogenicity, and loss of hilum and shape. And they also included the surgical and pathological details, and all the patients underwent total thyroidectomy with prophylactic central compartment dissection, and the lateral compartment dissection was performed based on the preoperative 5-needle aspiration report and intraoperative frozen section, which showed metastasis. Based on these reports, they have done the lateral compartment dissection, and the lateral compartment includes level 2, 3, 4, and 5. And they included the tumor size, multifocality, bilaterality, extrathyroidal extension, and BRAF status were recorded. And the histological reports, which includes the largest size, total number of the harvested lymph nodes, and total number of metastatic lymph nodes, and the ratio between these two, and extranodal extension are also included. The staging of the thyroid cancer was reassessed according to the 8th edition of the American Joint Committee of the Cancer. And thyroid cancer was staged according to this, which includes T1 includes tumor of less than 2 centimeters in greatest dimension, and T4 includes more than 4 centimeters with extrathyroidal extension. And regional lymph nodes, N1A is metastasis to the level 6 and 7, and N1B is metastasis to unilateral, bilateral, or contralateral lateral lymph nodes, which includes 2, 3, 4, 5, and retropharyngeal lymph nodes. All the patients underwent thyroid stimulating hormone suppression and radioactive iodine therapy with 50 to 200 millicurie after the surgery. And all the patients were followed with measurement of free thyroxine, thyroglobulin levels, and anti-thyroglobulin antibody and TSH hormone levels. And also underwent follow-up with neck ultrasound and chest computed tomography for every 12 months. And iodine 131 whole body scintigraphy and positron emission tomography were performed in those patients who had detectable serum thyroglobulin and anti-thyroglobulin antibody levels without evidence of recurrence on the neck ultrasound and CT chest. And they defined recurrence as a newly detected disease on biochemistry, cytology, and imaging after a period with no evidence of the disease. And no evidence of recurrence was determined with no evidence of disease on biochemistry, cytology, and imaging. The defined disease outcome of interest was recurrence-free survival, which defined as period from date of surgery to the development of tumor recurrence in patient with recurrence, or that of the most recent follow-up in patients without recurrence. The median follow-up period was 66.5 months. To compare the demographics between the recurrence and non-recurrence groups, the continuous variables were analyzed using students' t-test and categorical variables compared using chi-square test and Fisher's exact test.
Categorical
Okay,
variables. Yeah.
Okay. And for analyzing recurrence-free survival, a univariate, multivariate Cox proportional hazard regression analysis was used to estimate hazard ratios with 95% confidence intervals. Kaplan-Meier cumulative curves were constructed using the factors associated with recurrence, and disease-free survival curves were compared with 95% confidence interval using log-rank test. And statistical analysis was performed with SAS version 9.2 with probability of values of less than 0.05 were considered to indicate statistical significance. Critics. Hello.
Yeah, go on.
Yeah.
Kavya, can you unmute yourself? Perhaps get your video on as well and give your critique up to this point, please.
Sir, the first,
Get
study.
your video on, please, if you can, if you have the bandwidth.
Sir, I'm logged in with mobile net.
All right. Okay. Go on.
Sir, first, the question itself of the study is relevant because recurrence after N1B, where they would have done a neck dissection, like recurrence, it has high morbidity and high post-op complications.
Okay.
And the impact factor of the journal is high.
Yeah.
It's relevant, and the study has good statistics also, has been properly calculated, and all the inclusion and exclusion criteria and definitions have been clearly given, sir.
All right.
The disadvantage is it's a retrospective study.
Yeah.
And it's also a single center trial.
Yeah.
With the ultrasound, as was being discussed, ultrasound is very subjective. It's observer dependent.
Mm-hmm. That's good. That's good. But why do you think a single center study is a disadvantage?
In like the what do you say?
I would call it an advantage because you know you have known factors. You know, there are two experienced
external
radiologists.
validity can, but okay.
Yeah, okay. And it's all controlled. If you have a multi-center study, then you do not, there are so many more people involved and the quality of each one of them can be questioned. Okay, and uniformity is less. Here, uniformity is more. But what is the disadvantage of a single center study?
The validity of the study,
Not the validity. I think it is the numbers.
numbers also.
Okay, it's the numbers that you have, but they have 600 plus numbers here. And I think they have a good volume of work, and that I think is quite reasonable. So you would not term a single center as a particular disadvantage of the study. If you you rightly mentioned that retrospective study as a retrospective study, it has certain disadvantages. But if you look at the tables and the data, what do you think about the data collection?
It has all again, like even the data has been it has again been reviewed also, sir, by two
Yeah, it
separate
looks like the
areas,
data collection
and
is
the
very
data
good.
collection was good. Yes.
Yeah, I mean, we don't see many missing. One of the big points in a retrospective study is missing points of data.
Yes.
But here it looks as if it has been quite comprehensive. And if you did want to improve that even further, to get you see, there is a selection bias in retrospective studies,
Yes,
and we have discussed this before in previous journal clubs. If you did want to reduce the selection bias, what technique would you use, which has not been used here? There is a statistical technique that you can use.
Randomization.
No, that is in
can't-
prospective.
Yeah, but it was okay.
Yeah, go on. There's somebody made a. Hari, you want to say?
Propensity score matching.
Yeah,
Okay.
there's a concept called propensity score matching. You can use that to reduce the bias in a retrospective study. Any other plus or negative points? Hari, you have anything to say?
Sir, other than
apart
that,
from what
yes,
Kavya
sir,
has said? Yeah.
Only those missing. What I thought of, sir, even though it is retrospective, it is dealing with the cancer and recurrence, so quality of life could have been studied, sir. But the ends points has been met, but it could have been added. That is one point.
Quality
and the
of
details
life.
of surgery could have been made, but they have mentioned it like there's, but other than that, no other surgeries a surgeon did who like that is not there. So rest of all covered, sir.
Correct. They could have mentioned, they specifically mentioned the experience of the surgeons involved.
Yes, sir.
That I don't think I found that thing. Ravi, you have any other points to add?
No, I think it is fairly, as you said, despite the fact it's a retrospective study, there is not many lacunae in the data, which is good.
Yeah. Ramkrishna? Ramkrishna, are you there?
Yeah.
Hello? Yeah. Niranjan?
Sir, I had a couple of points. One was nearly 120 patients were excluded because ultimately the lymph nodes were negative.
Yeah.
But they say the lymph node evaluation was done, one by ultrasound, second by FNAC, and also by frozen section. So I don't know how they missed that amount of lymph nodes where they excluded. Whether that came into the bias or in the final analysis, I don't know.
I'm not with you on this. I seem to have missed it. I mean, just go back. Where were we? See, they included all the people where the lymph nodes were picked up on the ultrasound.
No, they've excluded 120 patients where the ultimate analysis in the histopathology turned out to be negative. Indraja, go back to this one.
Go back to that. I'm not clear with that.
Hello, can you hear me, sir?
Yeah, hear sir? Yeah.
No, what Dr. Niranjan was telling, they have given this flow chart. There they have mentioned why these patients were excluded. 10 patients excluded because of
the voice is not clear.
Other than not clear, sir.
Little louder, sir.
Hello.
He can hear you.
Yeah, go on.
Yeah, it is because the diagnosis was other than papillary carcinoma of thyroid, and a few cases distant metastasis was there, and diagnosed with other malignancies. Like that, they have mentioned about 5 reasons why those patients are excluded. So after exclusion, 837 has become 692.
Yeah.
That is the
so that's what I said. So there is, go on.
Comment-wise, I thought this follow-up period of 12 months to see the recurrence, it looks very short because papillary carcinoma, they are known to be very low-grade malignancies and the recurrence occurs very long time after surgery.
Median follow-up was 5 years, Ramakrishna, from 60 months. Yeah.
66 months. Yeah.
Yes, sir. But the data of 12 months also they have taken means this can skew the results.
Yeah,
That
it
one
is.
thing.
The shortest is 12 months, longest is even more, but the median was 66 months. Yeah.
Sir,
But that's true. It's too short a period. Yeah.
In that also there is a point where they have expanded that median follow-up from 4 to 60 months. Here they say they have excluded if any patient is less than 12 months, we have excluded them from the study. But in the ultimate analysis, they say median follow-up is between 4 to 60 months. 4 months to 60 months.
I don't think they've included 4 months, Niranjan.
It's there in one of the.
No, that applies to the 900 people they have operated on.
Okay.
But they have excluded the ones where it is less than 12 months. They very clearly said that.
Yes,
Okay.
sir, that they have mentioned. What I was feeling is, suppose if they take some patients who have got follow-up of only 12 months or 16 months, those patients are also included. And in them, they say there is no recurrence. Then that can skew the results and give a misinterpretation. That is one thing. And second point is, they have not clearly defined what is this hyperechogenicity. There should be some reference point beyond which they say. And just looking at the images, it is difficult because even in our experience also the sonology report comes with the images.
They have said it in the end, sir. More than I think 50 to 60% solid component to call that as hyperechogenicity in the discussion.
That is the quality, sir. That it doesn't make. I don't think that they call echogenicity.
Yeah. They have not defined it, but I presume that the ultrasonologists will have a definition for themselves. It is a bit subjective, undoubtedly, but I think they'll have that. Okay, that point taken. Go on, Indraja. Any other comments, please, from the audience?
My question is the research question.
Yeah.
They are asking for this ultrasound to predict the recurrence.
Right.
So all these ultrasound findings, they point to whether it is malignant lymph node or not. So once it is malignant lymph node, because these patients are followed up after histopathology, whether this ultrasound is better than histopathology in predicting the recurrence, that question is not answered in this in the main research question and outcome.
Right. The way I saw it, I felt that they were looking at the outcomes based on the reliability of malignancy on preoperative ultrasound. They really were not looking at recurrence rates or completeness of their surgery and completeness of their follow-up and things like that, which would take into account the characteristics of histology and post-op follow-up. But their question was, if an ultrasonologist says that there is a lymph node, lateral lymph node, which is likely to be malignant, now you do a standard procedure for it, would that in some way predict increased recurrence later? That was the question, I thought.
So that is where my doubt was, sir.
These
Nearly
cases,
120 patients were
done.
excluded after ultrasound that detected them to be positive. And in the follow-up protocol,
Niranjan, see, they had some criteria for exclusion and those 120 fall in that group. Yeah, that is why it is valid. There we have decided that their exclusion criteria are valid.
No, that is okay, sir. What I am telling is, they see all these patients have already undergone surgery, and you have histopathological report saying that lymph nodes are malignant or not, and you know what is the size of the lymph node, what is the whether there is extranodal involvement or not. So based on that, you can predict the recurrence rate.
Yeah.
So they should have compared this hyperechogenicity or whatever ultrasound findings they wanted. So whether that is superior to the histopathological prediction.
Yeah.
Because all these patients have already undergone. What is the use of finding hyperechogenicity and predicting the recurrence rate, because already we have histopathology.
Yeah, Ramakrishna, those questions have been addressed in other studies.
Earlier, correct.
So which is why they are looking at to see whether can ultrasound predict. Actually, they are not saying it will definitely, tell, predict that these are lymph nodes which you need to be careful about.
Correct.
That is all.
Correct. All right. Go on, Indraja.
Yes, sir. And my critics for a study, it is a recent study and relevant topic, and with the index journal with good impact factor, and they included good inclusion and exclusion criteria. And
Just point out anything that we have missed out, Indraja. There is no point
all
going.
points were covered by
Okay.
ma'am. Yeah, ma'am.
But you see, you have mentioned
That's
again single institution. We have addressed
Yes.
it. Single institution need not necessarily be a negative point, but
Okay.
where is the question of an informed consent in a retrospective, anonymized retrospective study?
yes, sir.
Okay, it doesn't exist.
Okay.
And in the paper, they also say that it's an
Yes.
anonymized retrospective study. So that is not necessarily a negative point.
Okay, sir.
Yeah, please go on.
Okay, sir. When you come to the results, out of 694 patients, 37 patients had developed recurrence, and of them, 31 patients had structural recurrence, including the lateral lymph node and thyroid bed. And 5 patients were showed distant metastasis in the lungs, and biochemical recurrence showing elevated thyroglobulin levels were observed in 6 patients. When compared to the two groups, recurrence and non-recurrence, male patients were high in recurrence group, and pathological tumor size and TNM stage is high in recurrence group, and multifocality and extrathyroidal extension were mostly noted in the recurrence group. Regarding the lymph node pathology, pathological lymph node size and total number of metastatic lymph nodes, lymph node ratio and extranodal extension were most commonly seen in patients with recurrence, and age, tumor pathology, BRAF status, and total number of harvested lymph nodes showed no significant difference between the two groups.
Hari, what is this BRAF status?
Sir, receptor status, sir.
Yeah, it is a genetic study.
Genetic study, sir.
Genetic study, and BRAF is now sort of sought after in many malignancies, including thyroid malignancy.
Yes, sir.
Okay. Indraja, you put a statement in red underneath.
Yes, sir.
Which is the finding of this study. Is there a variance of this with other studies that you know of? You would have done some parallel reading, I presume.
Indraja?
Yes, sir.
Age?
Hari?
Sir, I was studied with same result in one study, so I didn't see any difference. I didn't go through much.
There are many studies which definitely give age as a factor.
Prognostic factor, yes.
As a prognostic factor.
Yes, sir.
And while the number and BRAF status in tumor pathology, yes, there is not much controversy, but number of harvested lymph nodes, okay, in some studies do show, but there isn't a specific number like they specify for breast cancer and axillary clearance, for example. That isn't specified for thyroid as far as I know, but the total number harvested, the larger it is, the better it is. And a lymph node ratio, which is significant in the study, is also equally significant there. You understand? It's other studies. The lymph node ratio should always be seen in the light of total number of harvested nodes. That's a general cancer principle. Okay, if you have very few nodes that you have harvested, and if a good number of them are positive, then you can't say lymph node ratio is important. There must be some 12, 15, 20 or something like that lymph nodes done in your dissection, and depending on the number of nodes involved, that ratio will be significant.
Yeah, minimum data set it is called.
Okay, so
other thing here, even in this study, it have shown that age is a significant factor. I don't know why she said that.
Because no, it's not statistically significant. They looked at the p-value. It was not statistically significant in this.
Yeah. Okay.
All right, go on, Indraja.
According to the recurrence is mostly observed in the males, and pathological tumor size and lymph node size were more in the recurrence group.
Yeah.
And when compared to the ultrasonographic features of the index cancer and index lateral lymph node, tumor size showed significant difference between the two groups. And index lateral lymph node size was larger and hyperechogenicity of lymph nodes were more in the recurrence group. And there was no significant difference in shape, composition, echogenicity, margin, and calcification of the index tumor, and cystic change, calcification, and the shape of the index lymph node between the two groups.
Yeah.
Yes, sir. And according to the univariate Cox proportional hazard analysis, male and ultrasound tumor size, hyperechogenicity, and multifocality, extrathyroidal extension, and pathological lymph node size and lymph node ratio were significantly independently associated with the recurrence. According to the multivariate Cox proportional hazard analysis in preoperative and postoperative combined model, male age, sex, lymph node size, and lymph node hyperechogenicity were independently associated with recurrence.
So the age is important, as Ravi pointed out.
Yes, sir.
It depends on this test that they were doing. In one of the statistical tests, perhaps it was not, but in the other one, it was. Yeah, go on.
And a diagnostic performance of male, sex, older age, and lymph node hyperechogenicity for predict the recurrence was done. And among them, lymph node hyperechogenicity has more area under the curve with accuracy of 41.18%. And patients with hyperechoic lymph node had lower 5 to 10 year survival rate when compared to the hyper or isoechoic lymph nodes. And patients with more than 20 mm of lymph node size had lower recurrence-free 5-year recurrence-free survival rate when compared to the patients with lymph node size of
Larger
less than
lymph
20 mm.
nodes. Yeah.
Yes, sir.
Okay.
And this is the ultrasonographic images of the two patients who had recurrence. This image showing the metastatic lymph node in the left side of the neck, which patient had recurrence after the 15 months of the period, who had irregular hyperechoic lymph node on the right side of the neck, and the other patient who had hyperechoic and cystic had cystic changes in the lymph node had recurrence after the 48 months after the surgery. Critics.
All right. Abdul, you want to say anything about this?
No, sir. All the points are covered, sir.
All right. Hari?
No, sir. Sir, the groups recurrence and non-recurrence they are comparing, no, sir. But that is there any way to make it a little bit, it will be different, no, sir, heterogeneous or groups, or else we can't do it. I was not sure, so I wanted to ask you this.
I'm not sure what your doubt is. Hari, say that again.
Sir, is there any way the way analyzing recurrent and non-recurrent, no, sir? Group having recurrent. So, is there any way that other than the propensity we are putting for analyzing equal patient, no, sir? So, is there any way to avoid the heterogeneity for male more and etc.?
Yeah. I see what you mean. No, they should have done a propensity score matching. There is, to my knowledge, there is no other way. Ramkrishna, anything else can be done?
No, sir. They are just looking at the two groups, recurrence and non-recurrence. There, whatever the factors are there, initially they do univariate analysis.
Yeah.
And whichever shows significance in that, they will pick up only those features. And take it to multivariate analysis.
Yeah.
And there, when whatever is significant, they will give it in the results. That is the way they do multivariate analysis.
Yeah. Ravi, any comments?
No, sir. I think they have within the confines of it being a retrospective study.
Yeah.
The statistics have been applied appropriately, I think.
Niranjan?
Nothing, sir. Nothing.
Yeah. Go on, Indraja.
So my critics for the study is they have done the good statistical analysis and compared with univariate and multivariate Cox proportional hazard analysis, and they also made the survived analysis with Kaplan-Meier. And again, there is a large difference between the two groups, whether it is significant or not.
Yeah, it's not significant, because as we said, that comes within the confines or the limitations of a retrospective study.
Okay.
And why are you concerned about the treatment given? Does the research question factor in the treatment? And was there a difference? Because they mentioned the standard treatment everybody got, and the standard follow-up. So why do you think that was a limitation?
No, sir. If all the patients had developed recurrence, sir. No, sir.
Mhm.
After that, what they have done, they
Doesn't
That-
matter.
Yeah, I mean, they would have done whatever had to be done, but that's
Okay.
not that's not within the research question. That's why they have not given you that information.
Okay, sir.
And we have mentioned it before. You're right. They have not given us, treatment, information about the
Operating
surgeons. And it is
yes.
important that when you have a group of surgeons operating, that they mention about the experience of the surgeons concerned.
Okay.
That's important. That's
Okay.
right. Yeah. Yeah.
Yes,
Continue.
Indraja,
Yes,
sir.
Indraja,
Yes, sir.
the Cox proportional hazard analysis,
Yes, sir.
there are figures which range from 1.0 something to 3, and then some of them there is 8.
Yes, sir.
So what does that signify to you?
So, Cox proportional hazard analysis, they will calculate based on the hazard ratios, sir. If the hazard ratio is less than 1, they are negatively associated with covariate and the survival will increase, sir.
No, come again. I didn't follow what you said.
So they'll calculate the hazard ratios. The hazard ratio, if it is equals to 1, there is no relation
Difference between the two groups.
Two groups.
Agreed.
if it is
So
less,
higher difference, higher the number,
more is the
difference between the two groups.
Yes, sir.
Yeah.
So there is one which shows a figure of 8. I think it is the lymph node hyper intensity.
Echogenicity.
So it is more associated with the recurrence, so that means.
So that means that is what you need to understand. If it is less than 1, the chances of difference between the two groups is very minimal.
Yes, sir.
If it is 1, there is no difference. If it is more than 1, it depends on the number, how far it is away from the number 1.
Yes, sir.
No, sir, just a slight difference. See, if it is 1, there is no difference, sir.
If it is less, it is
less
less
than
risky.
1 by very huge amount, say -8. It is
Yeah.
as significant.
Yeah,
as
of course. Yeah.
It will be negatively
Correct.
associated.
Correct.
Here it is positively associated.
Positively
There
associated.
it is negatively associated.
Correct.
The range what they give now, if it crosses 1, then that is not significant. Say 0.8 to 2. So in that range, 1 will come.
Yeah.
If it comes like that, then we say it is statistically not significant.
Not significant.
If it is on the only positive side or only on the negative side, then it is significant.
Significant. Yeah, I agree. Sorry, I didn't mean to this one. I think you're right.
Yes, sir.
Go on, Indraja.
Coming to the discussion, the preoperative ultrasound features of lateral lymph nodes have the potential to predict the recurrence in patients with N1B papillary thyroid carcinoma. In the preoperative and combined model, ultrasound features of metastatic lymph nodes, including the size, hyperechogenicity, were independently associated with recurrence, in addition to male sex and older age. In this study, patients with larger cutoff of more than 10 mm and hyperechogenic lymph nodes in the lateral leg had lower 5 and 10-year disease-free survival rates than those without. And the previous study has reported that ultrasound features of metastatic lymph nodes, including node matting, cystic area, or unclear margins, were significantly associated with extranodal extension, which is an important prognostic factor in N1B papillary thyroid carcinoma. And similarly, other studies showed that suspicious ultrasound features of metastatic lymph nodes were significantly correlated with the pathological size, total number of lymph nodes, and extranodal extension. The presence of metastatic lymph node with maximum diameter larger than 2 centimeters was an independent risk factor for locoregional recurrence. This data suggests that ultrasound features of metastatic lymph nodes, including the size, hyperechogenicity, can be used for preoperative risk stratification of N1B papillary thyroid carcinoma rather than characteristics of tumor itself. This study highlights that preoperative ultrasound features of the metastatic lymph nodes can provide prognostic information before surgery and guide the surgical management. And the postoperative recurrence is a critical issue for both patients and surgeons due to the morbidity of the surgery as well as difficulties associated with the operation. And the limitations of this study, they have said that it is a retrospective study and single institution study, and imaging assessment was performed on the largest tumor of the lymph node, and direct node to node evaluation was not possible. although the imaging features were interrupted by the consensus of two radiologists, there may be operator dependency due to inherent nature of ultrasound.
Yeah.
Can I continue, sir?
No. Let's
Again, the same problem.
Yeah.
Limitation. Why they have mentioned single institution?
That's
as
what
a
I.
limitation.
Yeah. As I said, it works both ways. Single institution, numbers will be small. That's one. And if the two, the people concerned have limitations in their professional capacity, then that's a problem. Whereas you can argue if it's multi-institutional, then you'll get a variety of people, and it may annul the negativity of one or two institutions. But it works both ways. And as I said, I personally feel a single institution study is much better because you may say these are known devils. You know what their capabilities are, and it's much better. And standardization of collection of data and doing procedures is difficult if you have multiple people involved. Yeah.
I think protocols can be much better monitored.
Yes.
If it's single institution.
Single institution. Yeah. Absolutely.
If numbers are sufficient, single institution study is better. But here probably they have mentioned it as a limitation because if many institutes are doing the same thing and getting the same results, then it will give more validation to the
reproducibility. Correct.
Reproducibility. So
correct.
For that reason, they might have mentioned it is a limitation.
Quite right. Yeah. All right. Go on, Indraja.
And as mentioned before, both groups were well compared, and they have defined the recurrence and detection as clearly, and they have good follow-up, and they said whatever they said in the research that are concluded the same, sir.
Correct. It's important to note that the conclusions they have come to are backed by the data in that study.
Yes.
Time and again, including, yesterday, in every meet, you find that people give you conclusions from textbooks and from other sources. Not allowed. It must be supported by data in that study. Yeah, go on.
Yes, sir. And against, as they said, no evaluation was not possible, and it is an operator dependent ultrasound, and they have maybe compared with CT or MRI.
Yeah, that's one of the points I thought as well. Well, we've done so many things. They have done CTs on certain patients and MRIs where they could have had data and yeah, they could have compared the ultrasound data with the CT or MRI data. But I think they had very few numbers. Number one, that I'm guessing this because they have not given that data. And second, I suppose most of these CTs and MRIs were done post-op rather than pre-op. And their the index assessment has been the ultrasound examination of the index tumor and the index lymph nodes at the first pre-operative stage. So perhaps they didn't have enough data to compare. Yeah. Go on.
Yes, sir. In review of literature, and
study. Just a deviation from the thing.
Sure.
They have said that all patients have undergone radioiodine therapy. Is that standard, sir, all over the world?
I got the same thought, but I presume that all of them would have had some residual disease. Theoretically, if your total thyroid and your lymph node clearance is complete and you find no activity on diagnostic radioiodine study, then perhaps you do not need any therapeutic radioiodine treatment.
Sir, because you do make the the recurrence wherever the possibility are there. TSH AVID, because the TSH levels are anywhere between 15-20. So even definitely they would pick up once it is given. So why I asked this was because rather by serendipity, I think Kallur gives them all radioiodine therapy, whether we request for it or not. So he would have talked to the patients and convinced them and give them radioiodine therapy, which has happened to 2 or 3 of my patients. So I was a bit skeptical of this.
All right. Okay. All right, Indraja. Yeah, go on.
Yes, sir. Okay. It is in a prospective study, that is a preoperative staging of papillary thyroid carcinoma, comparison between the ultrasound and CT. And they have said that the presence of metastatic lesions increases the risk of local tumor recurrence. And for successful surgical management of PTC, accurate preoperative determination for the presence of lymph node metastasis is important. And it is also important, they have concluded that it is also important to predict the size of tumors and extrathyroidal extension preoperatively, because tumor size and extrathyroidal extension were the independent risk factors for tumor recurrence. And
Indraja, please go back. But it doesn't. I haven't seen this paper, to be honest. It doesn't concur with what is laid out in the title. What is the comparison between ultrasound and CT? What does that say? You're talking about generality of,
actually, they said that ultrasound is more actually more accurate in predicting these lymph nodes.
Really?
Compared
okay. Compared to CT. I see. Okay.
I'll post this paper, sir.
Yeah. Put it in a group. It will be nice to read the paper. Yeah.
Okay.
And Indraja, what other thing my doubt is, how differently would they treat these patients who have the higher incidence of recurrence? I don't know, the treatment is still the standard. Is there anything different you would do if there is potential for local recurrence? Apart from doing a lateral neck dissection, nothing else can be done, is there?
Yes.
So then what is the point of saying it is important to predict the size, this one? How will it actually, it will not change the management.
Yes.
But what it will change something which is significant. What will it change? I agree with Ravi completely. It doesn't change what you do, but it does say change something in the overall treatment of the patient. A soft skill. I'm going to give you a
counseling.
Hint. Yeah. You mentioned it already. Yeah. You can counsel the patient and expect, ask them to expect, a higher recurrence. And how is that important? You will have a higher compliance in follow-up, hopefully. Okay, you understand what I mean? If without scaring them, if you tell them there's a statistical chance that you will have higher recurrence, so please do not miss your follow-up visits. Do not miss your follow-up workup. If you say that, hopefully they'll listen to you. So that is why it is important.
Okay. Yeah.
Okay.
Okay. Right.
Yes.
Right. Go on.
In the other study, that association of preoperative ultrasound features and recurrence in patients with a classical papillary thyroid carcinoma, it is a retrospective study. They said that 56 of 500 patients had recurrence, and the presence of malignant appearing ultrasound features was independently associated with recurrence in patients with classic PTC. And the other study, that is efficacy of preoperative neck ultrasound in the detection of cervical lymph node metastasis from the thyroid cancer. They said that preoperative neck ultrasound is valuable tool in assessing patients with thyroid cancer. The highly sensitive and specific nature of ultrasound in predicting cervical lymph node metastasis in the lateral neck, especially in the setting of recurrent disease, can provide reliable information to assess the surgical management. In conclusion, the preoperative ultrasound features of the lymph nodes, including the size, hyperechogenicity, may be valuable for predicting the recurrence in patients with N1B papillary thyroid carcinoma. Thank you, sir.
All right. Well done, Indraja. I think it was a good presentation. Comments from your peers and your seniors. Hari.
They're well presented, sir. Sir, we'll think about these things because not like other difficult can be studied actually.
Yeah.
It is the interest of study.
Yeah.
So that is one thing I am getting from this paper, sir.
Very true. If you have enough numbers, you can have a prospective study. If it is retrospective, you can make it prospective and look at it.
Yes, sir.
That is something you should consider. Yes. Abdul?
A nice selection of the journal, sir.
All right.
We have not used this journal, I think, up till now.
I think I'll take marks for it. I can't give it to Indraja.
Yes, sir.
Anyway, she did present it to me. I must give her the marks for that. All right.
Otherwise, the presentation was good, and
yeah. I actually looked at it, the journal, before I recommended it, and it is indexed in Index Medicus, so it's got a high impact factor. Okay, because we haven't done this journal before. That is one of the reasons I chose that, apart from the interesting topic. Kavya?
Sir, that's it. Overall, it was a good presentation, sir. It
Yeah.
can be used later, like
Yeah.
converted into a prospective study.
All right. Niranjan.
Good presentation, sir.
All right.
Okay.
Ramkrishna.
Good presentation, sir. The only thing she mentioned about table 5, sir. Here, if you look at this table 5,
Yeah.
they have taken male sex, age, lymph node size, and hypergenicity.
Hmm.
The accuracy of age and sex, it is much more than lymph node
Hyper.
hypergenicity.
It's only 48%, you know.
41% for hyperechogenicity.
Yeah. Okay.
And age more than 55. It is 80% accurate. Even the area, that is also more here.
Yeah.
And the specificity, if you look at it, again, male sex and the age, they have more specific.
Yeah.
So whether we should use this, that last question, I think it will yet to come.
Yeah.
Whether it is clinically useful, do you want to use this in your practice?
Yeah.
I think it is
Very, very valid point. I also noted that low accuracy, but among the ultrasound features, hyperechogenicity seems to be a valuable tool. That's all we can say. Yeah, you're right. Hari, sorry, Ravi.
Yeah, that I think this is why I said that age, though they very strongly said age is not, but all their data shows that age is a very important factor.
Yeah.
And then this, I think the size of the node and the hyperechogenicity probably are, good guide to probably think that, we have to be careful, maybe do a lateral neck dissection as well as the central compartment. But good presentation, Indraja. I think you have improved by leaps and bounds, and your literature review is also good. You have chosen good journals to review the literature as well. Good.
All right. Thank you very much, everybody. I think it was a useful discussion. Thank you and good night.
Good night, sir.
Thank you, sir.
So tomorrow there is a Pavan. Are you there now?
No, sir. He is still.
Oh, still in emergency. Okay. I think tomorrow, no? Abdul?
Yes, sir. Yes, sir. Tomorrow.
Okay.
What is on tomorrow?
Morbidity, mortality.
All right. Okay. What's the case?
I think appendicular perforation with gangrene.
All right. Okay. All right.
Okay.
Yeah. Thank you. Thank you and good night.